So I'm William Britton. I'm the Assistant Facilities Director, managing support services. To my left is...
Hi, I'm Ralph Mansour. I just joined the trust. I was here as a contractor for a while and then just joined the trust as head of catering.
Okay, so to try and keep to time, I've just made myself some notes. So if you see my eyes looking down, I'm just talking through the time frame so I can try not to miss anything and keep it succinct as possible. So last year, around March 2020, we were in the process of negotiating with OCS the new retail catering development outside of the main entrance at St. Peter's when COVID-19 struck. The negotiations quickly stopped and we ended up with closed cafes at both Ashford and St. Peter's, and the PGC restaurants struggling to operate COVID safely. The current contractor, OCS, were not coming up with any solutions on how we could move forward with our retail catering services. And after a brainstorm meeting with our catering consultant at that time, Nella Davis, who was helping us with the previous tender, we decided to end the relationship with OCS and to contact one of the specialist retail caterers who usually do not tender for the NHS. This is because the NHS procure its services like it does a commodity in terms of 40% finance, go through PQQ and a long bureaucratic process. The large contractors resource for getting through this algorithm. The more specialist contractors, such as Bartlett Mitchell, focus on food, great service with executive chefs like Ralph, specialist project managers, baristas, the food on the plate. This is what we wanted at this time. Often the NHS works, when you buy something, it's normally predictable. When you try and work outside of the norm, which we were trying to do, the system can't react. And fair play to Simon Marshall and team helped us navigate through this. The next stage was to formulate a plan of action quickly. And to do this, we broke up into small groups to talk to the users and went out to many of the departments, nursing, ITU, theatres, outpatients, dietitian, and then asking the then acting Chief Executive, David Flood, what his objectives and tech's objectives were in re-establishing the catering back at Ashford and St. Peter's. So the feedback and the themes that we were getting from staff was the time restrained 30-minute break. They didn't want to queue for 10 minutes and go back. It was only 20 minutes then to eat, and so they were struggling to get off their ward for 30 minutes. Affordability was very important to our staff as well. Wanting nutrition, healthy food, and also sustainability. David and team gave us the objective of to open COVID safely and well-being, staff feeding. So we just had two clear objectives from the trust executives. August onwards, we brought in Bartlett Mitchell, which included Ralph, with these objectives in mind. The other success story at this time was when the hospitality industry was laying off staff, we were employing people to reopen our cafes and bringing in some great skilled people like Ralph to work for us. So why should the likes of lawyers, bankers, who normally he caters for, only get great food? How about our highly skilled professional team? The final bit of this project moving forward was to make it resilient. And this we have done through introducing some HR initiatives called Rounding, in which we meet with staff members regularly, involve them in the service, act on their feedback, and now have a process in place of developing and training our own chefs for the future. So what I find the NHS does is it goes finance, service, people. What we have done is we go people, invest in the people, involve the people. That informs the service. You get a great service that then develops the finance into a great service. So I'll hand you over to Ralph.
Hi everybody. As I said, I'm Ralph Mansour, just joined the trust. I came here about 7 months ago as a contractor. I was working for Bartlett Mitchell. It's a high-end B&I contract catering. We work for a lot of government offices, but also embassies, big companies, lawyers, solicitors, and everything else. COVID happened, and straight away from the onset, I think 2nd of March, I was put straight away in furlough. Couldn't visit any sites. Wasn't allowed to go anywhere. And straight away, that from furlough went to redundancy. Looking at redundancy, we were facing the company lost. We had 200 sites, and we're only left with 3 or 4 sites. Every office is closed. I was sitting at home for 7 months. Was looking at, as I said, furlough and redundancy. And then I got the phone call. Do you know there is a project going on? We got this hospital is not far where you live. Come and have a look what we're doing and have a discussion with the team. I was really skeptical. I'm gonna be honest. I was skeptical and disappointed. I was like, is that the highlight of my career? I'm going to a hospital. I actually text my boss saying, thank you for giving me a chance of working in a hospital. That was missing from my CV. I didn't think he appreciated it, but I said to him, I said, this is the highlight of my career now. I'm going to a hospital. He said to me, go and meet the team, go and meet Milliam, they'll explain to you the vision. And I was like, all right, I'll go and hear it. I've got nothing to lose. Come into the hospital, met William, talked to a few people around the trust. And they said, no, we want the same vision as you guys got. We want to align our vision with you guys. And I said, all right, it's going to be like a big experiment. We're going to offer something completely different. They said, yes, we'll accommodate you, we'll help you, we'll give you the freedom. I was like, oh, wow, really? They said, yes. I said, because what I heard about hospital procurement process and everything else and supplier is really rigid. Usually, this is why we avoid to work with. The procurement is driven, and in our cases, I want a niche supplier, I want a local supplier, I want to buy seasonal food. While I've seen the person, first things I checked is the Persian basket for NHS, and it was 70% of it frozen. I was like, oh, wow, I'm not touching that. Let's move on. Talked to William, and William said, no, we give you freedom. We'll get suppliers on board, and we give you freedom with suppliers. So start the project. We start putting part of the project. We changed the menu, changed everything. We changed the feel of the place, and all of that, and the COVID, and the food, and how we wanted to see it. Start putting the pictures on Instagram, on Twitter, and everything else. And then suddenly, my colleague who was on furlough, and everybody, the competitors, all the executive chef I was competing with around the whole UK, start getting phone call, and people saying, where did that food? Where did that come from? I was like, hospital. He said, we can't believe you're in a hospital. Did you go mad? I was like, no, that's a hospital food. And suddenly everybody who before was laughing at me, looking at me saying, can I join the team? Can I get something to do with this? It's really amazing how the things is, now we've got people followers, I've got colleagues, and they even want to volunteer their time to come and help because they think, oh, wow, the food is really great. For me, it's a humbling experience because I see a lot of people who's enjoying the food. I talk to a lot of people around the hospital, and I'm enjoying my time here. Decided to take the position as full-time. And thank you all for your trust. I'm really enjoying my time here.
I'm trying to show some slides. I don't know whether you can see the slides.
They're scrolling, William.
Yeah, we can see them. Yeah.
It'll only take a minute, so you can. It just gives a, and you can keep the slides afterwards. Just you can see the great food that Ralph has now trained the team. You know, the team can do this. So what we've also done is it was timely that we received the hospital food review. Came in December, And what the hospital food review said was that trust should view its catering in terms of well-being and don't look at it in terms of 2% off, say 2% off. Look at the value in terms of staff well-being, recruitment, retention, and use it as a tool. So that's been one of my biggest learnings from it, and hopefully you, the board, the team, will view catering in the same way. I think just about finished, and we're over to questions.
Okay, thank you, William. I'm going to kick off actually because I've got some thoughts. I think one of the most fantastic things you've done actually is in an outsourced operation, people have their own little job, don't they? You know, that's your job, you stick to that job, that's your job, you stick. What I've noticed with Ralph and the team is bringing on people, yes. Challenging people to do new things. Do you want to stop sharing your screen, if it's you, William?
Sorry, I thought I'd stopped it. I'll go, sorry, I haven't stopped it, sorry, Andy. I'm new to this.
And actually challenging people to do things they haven't done before, to improve their own skills. And I think just bringing up different members of the team, absolutely fantastic. I think the ambience, the quality of the food, and as I think we were talking yesterday or the day before, you now have a popularity problem in terms of queues of people at the peak times, which I think is a great problem to have. And I think our challenge obviously is now to reproduce that or something equivalent at Ashford. But I just want to say, you know, and also the one of my memories of this time is the queue for donuts when you did the donut day was just phenomenal, and I was very pleased to have one of my 5 a day because mine was an apple and cinnamon one, so it was clearly very good for me. So I'd just like to say thank you. I think you're doing a brilliant job. So I'm going to open it to board members.
Can I just say one thing that I missed as well? So part of the hospital review document said was look at the pay structure that you've got in place in terms of your cooks, chefs and commies. So as part of our 2P process, bringing on in-house, we actually looked at, so we've got our chefs from band 5 to band 4 to band 3. So starting at band 2, they train as commie chefs to band 3. So we put in place a resilient succession planning that Ralph and team can work to and recruit to going forward, because we don't want this to be a 1-minute wonder. It's how can we now keep it, evolve it and develop it.
We offer career progression now, which is really, when I worked in the commercial side, we always had a training plan and career for our chefs. When I come in, I thought the first things I do is introduce that to the team. The team can aim. So the commie chef, the GA that's aim at commie chef job, the commie chef for the sous chef for the head chef, and the head chef for the manager job. Them guys offer them career. Then they don't have to leave. They don't have to look everywhere else, and their skills level will go higher. My job is to challenge them and to get the better out of them for themselves. And recruitment will be easy in the future because hospital catering will be looked as a career, not somewhere that somebody think, oh well, I finish here, so I'm staying here. I said to the team is in 2-3 years time, I want to see every single one of them progress through the ranks. That's a challenge, and that's me promise that to them. The idea is I promise you that because I realize you're working hard, and we owe you that progression, part of giving you a career, giving you a voice and a career and something to look forward to.
Great. Now I'm aware that obviously our non-execs, probably most of them haven't experienced this, although Jane and I did pop in yesterday. So questions. So Andrea, I think you were first off.
Yeah, it was just to say I have had feedback actually from some of the staff working with Ralph, and you know, they're absolutely overjoyed at the new skills that they've learned and what you've really brought to them. Rosie in particular was amazing, has been amazing at doing soups, but she's just doing flip flacks at the new skills that she's learned. So a huge thank you. Great feedback coming back. And the other point was about the national recognition that we're now getting, which is just wonderful, isn't it? Actually, we're being held as an exemplar
Yes.
around this. And again, to do that in such a short period of time, I think is real credit. So just huge well done. And the fish and chips on a Friday, OMG, at the gastro pub, quality, all your stuff's really great, but and very, very popular. So fully recommend those.
Thank you. I'm really proud of the whole team. They embraced the changes. Usually I open a lot of different sites, and usually the initial reaction, they all push back. I don't want to know. I always done it this way, which is the famous saying is, we always had it this way, always done it this way. The minute I start challenging them, they start accepting it. And the minute they start accepting it, they embraced it. The skill level is going high. Rosie is never touched baking. Now she bakes all the cakes on site. When you think about 90% of the food, more than 90% is produced on sites, including all the sauces and everything else. It's amazing. It's the guys, they're willing to learn, and they credit to you guys. I only come in and just slot them in a place, find them a home.
Right. So, David.
Well, I just wanted to say thank you to William and Ralph. I think it's absolutely inspirational. And I think William and Ralph, Chris, and the whole team, you've done an amazing job. And I think as Andrea was saying, you just sense the pride in the team. And I suppose my overriding memory, William, is for a time, every time I came in the hospital, you collared me with your latest innovation idea. And that was just so brilliant, is that it just didn't stop. You were like a kind of stone rolling down the mountain when you got going. And it was just so exciting to see the team come alive in the postgraduate centre, and the number of people wanting to eat your food. I think my other thing to say, it does feel a bit like we're in Italy now, because the staff talk about food rather than the weather now. And my two sons who work in the hospital, they're always comparing notes, the portion size they each get, and they give a kind of a précis on what the food was like, and it's always great. So I'd just like to say thank you. I think it's absolutely amazing what you and the team have done.
Thank you, guys.
Louise.
Thanks, Andy. Thanks, William. Brilliant introduction to this story, and thank you to Ralph for being so honest and true to yourself, but illuminating to us what a brilliant story this is. One of the things that I wanted to do, Andy, was just to bring Chris in, and I think he's put his hand up anyway, so hopefully he's going to turn his camera on and we can see him. Chris is our Director of Facilities and Estates, for those of you who don't know Chris. And Chris and William came to the execs this week with Tom just to talk about sort of the next phase of this. And so it might be useful just to hear from Chris in terms of his thoughts, and in particular kind of the infrastructure that the team are working with and how we need to improve that.
Thanks, Louise. Yeah. Hello, Chris. Welcome.
Hi, Andy. Hi, guys. They say that great leaders dare to appoint staff who are better than them and just keep them pointing in the right direction. So I must be a great leader because I'm appointing better people than me all over the place. This is a really good news story, and it shows that good things come out of adversity. And there's been a lot of adversity through COVID right across the trust. I did catch up with the execs earlier in the week, and we had a really good session looking at the way forward, because we've reached a point where everyone's talking about food, and then you start to scratch your head to say, well, how can we keep on the top of the wave? We don't let the wave crash. William's retiring, so we need to keep the momentum up. So we discussed that, and the three things that struck us that we need to work on the hardest in this next phase is one that we've mentioned, Ashford Hospital, and how we bring up the standards to be the same at there, albeit in a very different hospital. Two was out of hours. to look, we provide a superb service during normal hours, but how can we look at out of hours? We can't provide the same service, but how can we provide a quality service and something the night staff start talking about? And finally, the tricky bit is our infrastructure. The guys have been providing a quality service from a very poor infrastructure that was only meant to exist for a short period of time whilst we built the front of the hospital. Well, plans and times have changed, and also catering and what catering delivery has changed and will do post-COVID, and how that's presented. So those are the three things. So there is some money for infrastructure that is required to help develop the service. That infrastructure will have to change in the way it looks and the way it provides its service. And we're starting to think about how that can happen. So I think that those are the three things, and are really useful. And through COVID, I think William's perfectly right. The execs did help us as well. They gave us free rein. We did things in procurement that we wouldn't normally do. David and Simon and Tom and the team really did help us. So they gave us our rein, and they also risked that we'd get it right. And I think William and Ralph did get it right, because I think they're the two central players in all of this. Thank you.
Thank you, Chris. And that's a good challenge, that because we've got to keep moving, haven't we? So I've got a question from Lord Andrew Mawson.
Oh, thanks, Andy. Yeah, it's really good to hear from you, William and Ralph. And what your description, we didn't ever manage to meet you because COVID hit us at the point we were due to start to meet you, but it didn't happen. This story you tell absolutely rings bells with the story my colleagues and I have come to understand over many years, which is about people and is about learning from business experience, as you say, Ralph, actually, and that large parts of the structures of the NHS are about process and structure rather than people and relationships. And it is a conversation we began a while ago with the hospital about what happens when you take people seriously and you liberate them and enable them to do the kinds of things you're now describing, which is very encouraging. And I haven't been to the hospital for quite a while because of the COVID stuff, but I will come and taste your food next time I'm there, definitely. The question for the hospital and the board, because one can see these disconnects right across the public sector and across the public infrastructure in the NHS in Surrey, as we ever more dig into what is happening in Surrey, is what is the learning? And what is the hospital and the other parts of the NHS locally going to do about a set of facts that have now appeared that everyone is literally tasting, so that not only does it happen in food, but happens in a whole range of services that starts from the proposition that begins with people and relationships rather than structure and process. Because my colleagues and I cite across the country on the NHS is that it's a profoundly broken structure, precisely for the reasons in the micro that William and Ralph are describing in the food element of this one hospital. So it's the challenge for the board and the hospital I place with you is, how do we actually learn from this? Certainly, how do you share the experience? And I'm not surprised at all, William, that there's national interest in what is going on here, because I've been through that experience myself, and it can happen quite quickly when you do these kinds of things, because people say, how do you grow this stuff? And you liberate people. So I just share with the board the thought, and can't do it today, is what is the learning and what are the implications of this learning for more widely in the hospital and more widely in the systems, both in Northwest Surrey and across the public sector.
Thank you, Andrew. I think that's a really good challenge, and one that I think we're up for. Suzanne.
Yeah, no, thank you, Andy, and thank you, William and Ralph, for an absolutely inspirational presentation this morning. And it just makes you smile listening to you talk with your passion and your energy and your commitment. And certainly my experience was, and this essentially happened while I was out of the trust, while David was leading you and the executives. And what a remarkable change I saw when I came back, and it was just amazing. So thank you to everybody who was involved. And what's brilliant is you continue to evolve it, think about the future. Chris, thank you for those words, and the piece around enabling our people to do something different. And so, Andrew, you took the words out of my mouth, really. Well, how do we take this learning, apply it to other parts of what we do, and how we deliver care and how we organise ourselves? And I think that is worthy of some really detailed thinking with you, actually, William and Chris and Ralph and everybody. What was your experience, so we can try and encapsulate that in some form of learning that we can share and enable others with? So I think what you've actually achieved is enormous, but I think it's got much bigger impact than might on the surface appear. But certainly without your energy, certainly William and Ralph, it would never probably have happened, because we often try to give colleagues the space, but they find they're too busy or too constrained to take it. But you took that and went with it, and you've just done a remarkable job. So, and I can, like everybody, I can vouch for the quality of what you do. And Ralph, I love the little mini boxes, and I love the special Easter biscuits, and I love the Christmas market, and all the added things that you do that just wouldn't have happened before. So, and I'm so pleased, Ralph, to hear you've joined the team on a permanent basis. That is just fantastic, and congratulations on your appointment. Just really great. But yeah, let's work with you to work out what the learning is, so we can apply it elsewhere with your support.
Thank you.
So just before we let you go, guys, and I know lunchtime is approaching, so that will be important. I'm aware that William, this is a kind of big week for you, and I have to say, when I heard the words William and retiring, I thought, no, William's not shy and retiring, but actually people meant that you are leaving us at the end of this week, and I shall be really sad to see you go. And I know the whole board is very grateful for the work you've done. I mean, over I think 14 years here, and a lot longer with the NHS. And I know you don't want to fuss, but we wanted to thank you. And really, you've done a fabulous job, and we will really miss you. I'll miss being collared in the corridor at all times, and having my ear bent. And
Dave, if I can find David or Susanna, whoever walks in the corridor, I love you.
Exactly.
You're welcome.
You do a great job doing it. But enjoy your retirement. Not quite sure what you're going to do next, but we just want to say from the board, and I know there are lots of governors on here as well, and from the governors, I'm sure, a big thank you for all you've done for us over the years. So thank you very much.
Thank you, William.
Well done, William.
And Ralph, we're looking forward to you taking this to new heights.
I am looking forward to. I'm only starting now.
Absolutely. And speaking for myself, one of the great joys of walking down there to either have a cup of coffee or to have some food is the happy, smiling faces of the staff there. And you've got people who are naturally like that, but actually everybody's really happy down there. And I think it's, you lift morale of people that are coming in there, and that's really important as well.
They are a great team, so I got no complaints.
All right. Well, thank you ever so much for taking the time out to come and talk to us this morning. It's great. These staff story slots and patient story slots aren't always completely positive, but today's been a fabulous one, and thank you so much for that.
Thank you.
Thank you, William.
Thank you.
Thank you, guys. Thanks, William. Thanks, Ralph. Thank you, Chris.
Okay, everybody. So let's now move on to the rest of the meeting and start with any declarations of interest, please, from any of the board members in anything that's on the agenda. Okay, so I've got a few welcomes to do. We've got quite a lot of people on the call today. We've got some governors, we've got members of the public, we've got some of our NED applicants, I notice, on the call as well. But I wanted to give particular attention to our colleagues from the CQC, Wendy Kaharska and John Marillett-Bush, and just give them just a brief moment to introduce themselves. So, Wendy.
Hello, everyone. And I've just got to say that was such a story of inspiration, because I really am passionate that good nutrition improves health. So staff wellbeing and good nutrition are definitely the way forward. I have a background in maternity. I'm a midwife by trade, and I have pulled my hair out many times at the hospital food and the catering in the hospitals that I've worked at. So what a fabulous story to start off with. So well done, guys, because I think that's the way forward for every trust. I'd like to say hello to everyone. I have recently taken over as your relationship owner. I have a tough act to follow because Sue Johnson was a really, really good inspector. I've been with the CQC now for just 2 years. I had a smaller trust to start off with, so you're my first opportunity at a full-on acute service, and I look forward to working with you all, and I hope that we can together improve outcomes for the people we care for. Thank you.
Thank you, Wendy. And I know your colleague John is on the call as well. John, do you want to say hello?
Good morning, everyone. Yes, I'm just shadowing the meeting today. As Wendy was saying just then, she's your relationship owner, but as a new inspector to the hospital's directorate, I was very, very grateful for the opportunity to be able to listen to you today. My background is in nursing, and I've been with CQC for 2 years. I must say, first off, that the start of this particular meeting, that was very emotional and really did give a wonderful outline of what this trust is quite clearly doing with their workforce. And I think it's such a valuable thing at this moment in time when you're thinking about the pressures that the staff are under, and everything is primarily based towards safety, and that's a very, very important quality to ensure that we work towards. But I think for myself, I am personally quite touched with the way that this board meeting has actually begun. So those are my comments for now, and I'll allow Wendy to continue to lead from a CQC standpoint if there is any additional things you'd like us to add today. But thank you so much for your time. I really do appreciate it, and have a wonderful day, everyone.
Thank you, John. Thank you. And as well as welcomes, and we do welcome the CQC. We've had a good relationship with Sue over the years, and we look forward, Wendy, to working with you. You also have to say goodbyes occasionally, and we've said goodbye to William. But this is the last open board meeting for Neil Hayward and also Keith Mulcairn, but Keith isn't here today. So I just wanted to put on record a huge thank you to Neil Hayward for his insight, for his calm and helpful advice over the years across a huge range of subjects. You know, he has a very quiet day job as HR director for HS2, but he has helped, I know, Louise, our side, helped us all on that side, but also on modern healthcare, and indeed leading the Strategic Change Committee. So a great input across a huge range of things, considering your very limited time because of your very busy day job. And I just want to put on record a really big thank you. I've worked with you before, Neil, and it's been a pleasure working with you again.
Thank you, Andy. That's much appreciated and quite a surprise.
Okay, so for the business, this is for those members of the public. This is a meeting in public, not a public meeting. Do please keep your microphones on mute. If you're having issues with things flickering or anything like that, I would advise you turn your cameras off because it's often a bandwidth issue. And we will only take questions that have been submitted in advance as per our notice on the website. But Liz, I don't think we've had any questions for this particular meeting, have we?
No questions for this meeting.
Okay. So with no further ado then, we will move on. And apologies, Liz, please.
Keith McCoran, Non-Executive Director, and James Thomas, Chief Operating Officer.
Okay, thank you. And we wish James well. I know he's off sick at the moment, so we formally record that all will be well with James, and he'll be with us very soon. Okay, I'm going to move on to the minutes of the meeting held on the 1st of April 2021, and I'll just go through them on a page-by-page basis, and please put up your hand if you've got any amendments. So starting with page 1. And 2. 3. 4. 5. 6. 7. 8. 9. And page 10. 11. 12. 13. And 14. So any amendments at all? I'm not hearing any. Good job, Liz. Well done. So we'll take those as agreed. And we'll move on to the action log. No open actions. Liz, the only thing I noticed was the action, one of the closed actions from the 31st to the 10th, 19, where it says on agenda as the ongoing thing. I think that should now be closed or complete.
Yeah, I shall update that. Thanks.
And that was the only point I had on those. Okay, so we'll now move on to my report. In the interests of, as we were going through the pandemic, I've kept this reasonably short and just really want to point to a few things. I think we've obviously seen the number of patients, as Suzanne will go through, fall, and last Friday I was delighted to see that we had at that point no COVID patients in the hospital, which was the first time for, I think, about 14 months, which was a really big milestone, and that was great. And the focus now obviously on elective recovery and the use of Ashford in particular, which is absolutely key to what we're doing. I think one of the highlights for me has been on the recruiting, and we had another consultant panel yesterday where we had again 2 great candidates, and I've been seeing constantly now the standard of candidates coming forward on consultant panels really improving and giving us a really hard job. And many times actually when we're there, we're saying, actually, you know, there's more than one here, let's look forward a bit more and we recruit more than one. And take the longer term view. But I think we are attracting better candidates is the not in every discipline, but in many disciplines. And I think that's a credit to the team, and particularly the executives who are doing such a great job on that. I'll also spare the blushes of those non-executive director candidates who are on here, but we've had a superb response to our advert for non-executive directors as well, and giving us again a hard task going forward, but it's one obviously that we relish. So I think the reputation of the trust in attracting high caliber candidates is really progressing. I know Suzanne will mention it, but on the Pride in Nursing Day, I was absolutely delighted to see our own Charlotte Broughton being given the Silver Award by Ruth May, and a really well-deserved award as well. For those of you who know Charlotte, you know, and she was desperately trying to say it's not just me, it's the team and all the rest of it, but she deserves that award. I've given a few vignettes of things that are going around. David and I had a fantastic end of rotation meeting with some of the overseas doctors. They were explaining some of the projects they've done, and I think we were both really impressed with the detail that they've gone into and their push. I personally am delighted to see the return of the presentation of pressure ulcer certificates for those wards that get through it. And last time I was reported on Maple, and this time it's Baku. And it's great to, number one, it's great for me to get back in and see the staff on the wards, but really good in these really busy times that we're getting that quality through. And obviously we know that COVID has put particular pressures on pressure ulcers, but there's difficulty on that. And then I think the last thing I wanted to draw attention to is the Schwartz round, where executives were brave enough to share their experiences from COVID. And obviously we won't go into any details because that's the whole thing about the Schwartz round, but I think people found it very, very helpful and cathartic, as always, on the Schwartz round. And moving to the team talk that we had last Friday, where we had 2 non-executives, 2 governors, and some clinicians talking about reconnecting and their feelings about some people who've been at home, some people who've been on the front line, and all the sharing of experiences, which was really, I think, quite moving. And it's good to see the number of staff that actually dialed into that team talk. So I'm not going to say any more now, but I will open to any questions on anything I've written in that report. Okay, good. All right. So in which case we'll move on and we'll move on to your report, Suzanne.
Thank you, Andy. So colleagues will recall that this is our evolving new form of Chief Executive Report, which is in 2 parts. The first part aims to bring a summative view as a result of the work that is led by the non-executive directors chairing the subcommittees that hold assurance responsibility and oversight for each of the strategic objectives, their review of the BAF with their executive and other colleagues, and their assurance sought and gained around the mitigations. And I think in terms of the shift in the position that we are seeing, I think from the beginning of our approach to this work, we have seen a very great deal of risk coming to the delivery of quality of care through primarily 1 or 2 factors, predominantly driven by the pandemic, and that the mitigation to that has been borne largely by the extraordinary efforts of Team ASPH, with the associated risks to their well-being and resilience. And I'll come on to the detail around those factors. The second part of my report you'll be more familiar with, which is bringing to attention of the board many of the great things that are happening within each of the strategic objective areas and domains. So my summative view would be, and this is born out of the conversations that have been held in each of the subcommittees and with the executive leads for the portfolios, is that what we now are seeing is a diversification of the risks and the factors driving the risks, but that in some, the implication is very much in the same place. So there continues to be clear risks to the delivery and achievement of our trust strategy, that being to provide an outstanding experience and the best outcomes for our patients and teams. But those are that is being drawn now from a number of areas and factors, which I'll briefly cover. And that the mitigation essentially remains around the bearing on our people, i.e. they continue to respond amazingly well to that range of factors and challenges in the mitigation of risks through the delivery of clear and coherent plans that are worked through the leadership of the organisation and then assured by yourselves. But with that comes that bearing on their well-being and resilience. And I know that the People Committee and Louise and her team, supported by the wider team, give a great deal of effort and emphasis to the many things that we're doing to address the consequences of the bearing on the team. And some of that you've already heard this morning in the conversation with William and Ralph. In terms of the quality of care, we've got the pre-existing, but I would say now evolving risk around the pandemic. And whilst we are seeing now very low numbers of patients in the hospital, which is really good to see, we, as you know, pay very close attention to the community levels of transmission and prevalence. And essentially the picture is low but flat, and certainly over the last 2 weeks we have seen increasing numbers in the community, which again remain low, but the prevalence is moving about within quite a narrow band at the low end of the spectrum. Nevertheless, what that tells us is that the virus is still in circulation in our local communities and still presents a risk to both patients and also potentially to the Trust's ability to respond. And of course, now we have, which you'll all be very familiar with, the added concern of new variants of concern. We're also we have proximity to the managed quarantine facilities at Heathrow, and we monitor demand arising from that, but we're not seeing a great deal of demand. The next factor that's bringing to bear in a heavier way is we are seeing a resurgence in heavy demand on the emergency care pathway, and it's true to say that over the last month or so that demand is both meeting and exceeding pre-COVID levels of attendance at the UTC and the emergency department. Of course, the various flow and infection prevention control measures remain in place, and so responding to that demand is a challenge, let's say. And I think we are clearly we are in conversation with the system, and in fact the media piece running this morning is around a 20% in uptake in primary care throughput. So, you know, we hear from patients attending that the reason they're with us or indeed in the UTC is because they can't get a primary care appointment. But it is true to say that our colleagues in primary care are working incredibly hard and actually meeting a great deal of additional demand. So what that tells us is that the demand generally is exceeding our ability to respond. And we need to think with our partners in primary care and out in the community services and in fact in other services, which is the work we're doing, about how that demand is mitigated and responded to differently. Then the next level, which is really coming through now, and we can talk to in the performance report, is the requirement to restore our elective care pathways and our diagnostics. And we'll come to that in detail during the report later in the board meeting. But actually, the requirement to do that, which at the moment, we have committed as part of the system response to achieve something in the region of 110% of 2019-20 levels of activity is requiring a huge amount of resourcing and reconfiguration of services. The work at Ashford, as you know, to establish our elective centre alongside care pathway improvement work is also another demand on our fabulous team. So I think you can see that we've got a huge amount of demand coming from a range of areas that could impact on the quality of care delivery. And then the last risk in the quality domain remains the unseen or concealed clinical risk sitting within the latent demand that we have not yet had contact with patients who are just now coming to primary care or directly to us with problems and concerns that they have not managed yet because of concerns about exposing themselves to the risks of being out and about, or in fact not wanting to bother the NHS because we're terribly busy. I think I've spoken about the levels of demand on our people because it's our people that respond to all of those risks, so I won't dwell on that. With regard to modern healthcare, I think we've already started to reflect on it. I think the financial risks are more prescient now than they have been recently, both in terms of the arrangements for the budgetary setting for the forthcoming financial year, but also as we've reflected this morning on the need to respond to a national financial position and the constraints that are being in discussion around the capital programme. And this is a very great concern to us because it could mean that one or two of our really significant capital investment programmes that we had planned for this year and which we have raised the cash through land sales may not be able to progress. Principally the refurbishment of the emergency department and the refurbishment of Abbey Wing and particularly the maternity theatres. Not progressing with those projects brings both very real quality and safety concerns as well as the impact on the morale of the team who are very much looking forward to and been engaged with the plans to bring those things to bear. So we need to manage both risks, the risk that we're not able to deliver those capital programmes in this financial year potentially and the impact on the team. And of course, as you would expect, the board are supporting predominantly Simon and myself in negotiations at system level and indeed with region and national leaders about the implications and the extent to which we can mitigate that potential risk.
Suzanne, I think we've got a question from Neil.
Oh, my apologies, Neil.
It's just an observation. I mean, firstly, thank you for this revised, changed format, because the comment that you make in the introduction around intended to provide assurance to the board that you are effectively leading the organisation. This report really does that. I think you could read this report, and I'm sure potential NED candidates and other guests are reading this report. You could read this report and it gives you an incredibly succinct, really good overview, grip and grasp of all of the current issues affecting this organisation at the moment. And the contrast between this and the sort of management information or discussion that we had facilitated by your updates compared to 5 years ago, this is chalk and cheese. It's an incredible step forward. It's really, really helpful to see. And you've drawn out the main point, which I think I wanted to note, which is the financial point that you've raised, which obviously does get discussed in detail at Modern Healthcare, is integral to what happens to this organisation next, because we had plans to spend that capital, and our transformation journey in the interests of patients and communities that we serve locally could be impacted, and I'm afraid, we're all afraid, I'm sure, potentially derailed if that does not come through to a safe resolution. So I know you're working hard on it, the team are working hard on it, but thank you for bringing out that point, because it's probably the most disappointing news I personally have heard as a non-executive director for quite some time, that having navigated through tremendous uncertainty as you and the team have done over the last 16, 17 months of COVID, to find that we might now not be in the position that we intended to be in restoration of services and improvement of facilities for patient care and also for staff is a concern. But your report tells us all we need to know, and we know you're on it. So thank you.
Thank you, Neil. I mean, my reflection on the capital challenge is an utter mirror of yours. I mean, devastated wouldn't put too fine a point on it. And of course, from a leadership position, what we'll need to do is lead our team and take the opportunities that do present. And there are opportunities. We've got the new primary assessment unit now very well progressing in terms of build in what was the old ED car park. Tom and I got our yellow hats and surcoats on last Friday in the snow and the gales, and went and had even including a view on the roof, and it's going to be an incredible space, and it is going to bring an awful lot to the delivery of care in our emergency care pathway. And of course, that's what we will need to work with our colleagues on and ensure that they feel confident and assured about in terms of the positive benefits. But you're also right to say that in terms of our plans and the ambitions we had, yeah, personally quite devastating that they may be curtailed. Really, as much for the quality benefits we'd bring to bear for the patients, but equally from the point of view of the teams that have been so very much looking forward to getting involved in those plans. So thank you for your reflection, with which I concur entirely. I think in the digital field, just to finish off, I won't take up much more time. We've got this amazing Surrey Safe Care programme, which is our electronic patient record partnership, really in full flight now with our colleagues at Royal Surrey. And we are having to review our approach to the go live of the system. And we have taken the opportunity to bring that together. And we are currently planning to do that just before Christmas in a phased and obviously clearly mitigated and supported way. And I think that actually gives us a great opportunity. This is something really wonderful for the care of our patients. It's going to be a great team enabler, and we've got that opportunity now. We've got a firm date to go to. We can use that as a golden opportunity to bring positive momentum and a morale boost to the team. So in fact, that in many ways, although that will also bring demand on them, I think it's also a mitigation to some of our resilience and wellbeing challenges. And then finally, just to say, I think that from a collaboration point of view, and we will also cover this in more detail later in the board papers, the team are doing incredible work working across the system around the transformation agenda. And what we are trying to hold on to very clearly is that this is a transformational opportunity, and everybody doesn't just, because of the tiredness and exhaustion that we all feel right now, that we don't just slip back into business as usual and lose those opportunities. So just to reassure the board that certainly the executive team have got a very firm eye on the transformation opportunities. And I think, just going back to William and Ralph, from small things, big things can happen. And as Andrew said, great deal of learning in there from that point of view. So I think to sum up, the range of risks are significant. They are impacting on each strategic objective in a diversifying way that we probably haven't seen since the beginning of the winter. But the cumulative effect is that the risk remains to the quality of care, and that our key mitigation remains the tremendous efforts and sustained commitment of Team ASPH, which is why the wellbeing agenda needs to remain very foremost in the board's mind. There's a great deal of detail in the report, and I know the non-executive directors will speak to their objectives as we go through, but happy to take any questions with their support and that of my executive colleagues before I move to part 2.
Thank you, Suzanne. And I think we might take part 2 as read, given the timings.
Happy with that.
But I think the great thing about part 1 of the report is if anybody wanted to know what's going on in the hospital and what the risks are, you can pick up this report, a bit as Neil said, and read that, and it really takes you to a very good place. So I think you and the team need to be commended on this developing, and I know it's still developing, report, but it really does kind of focus the mind, doesn't it? So
yeah,
very good.
Thank you, Andy. If we haven't, yeah.
Questions for Suzanne on this? Or indeed on anything in part 2 as well?
Yeah. If I might, Andy, because you sort of pointed to it, could I invite Andrea to just give a few words on Pride in Nursing and Midwifery Day?
Yes,
would
please.
that be okay?
Yeah.
If no one has any questions on part 1.
It was a great day.
Andrea, it was your day, so you give the out brief.
Oh, bless. Well, it was a terrific day, and it was it was on the 14th of May, so a week last Friday we had it, and obviously we weren't able to celebrate it last year due to COVID, and we had to cancel that. But thankfully, nationally they'd rolled over the International Year of the Nurse to this year because of not being able to celebrate it last year, which was aligned with Florence Nightingale's 200th birthday. And it turned out to be absolutely brilliant. I mean, I was a little bit unsure because of the way we were going to do it this year was a mix of virtual and also people being present, obviously socially distanced within our different lecture theatres. But we managed to actually hold the event over 2 sites. So we did it at the main speakers coming out from the lecture theatre in Ashford, but people were present in the lecture theatre in St Peter's, and obviously we were beaming it virtually, so people could join virtually, which was lovely, and also recorded it. So we've got it for posterity, and people can watch it and catch up with it afterwards. So I think it's turned out to be an exemplar of what we should do going forward, really. And a big shout out to the comms team who facilitated it and enabled us to do that for the day. But wow, we had such a lineup of speakers. I mean, it was like a national conference, really, in some respects. We started off with Greta Westwood, who's the Chief Executive of the Florence Nightingale Foundation, gave a very inspirational talk about her journey as a nurse, which really resonated with a lot of people. And then obviously what the Florence Nightingale Foundation can do for us as nurses and midwives, but also the support that they've given through COVID, and that was quite illuminating. And then following on that, we had Andrea Sutcliffe, who's the Chief Executive of the Nursing and Midwifery Council, who physically came to present. Actually, it was lovely to meet her. I hadn't met her before. And again, she gave an account of what the NMC have done really during COVID to support and what they're looking at doing going forward as well. So that was terrific. We then had Ruth May come and join us, and she did an inspirational chat thanking all of us really for our efforts during and COVID, and then it was lovely for her to be able to present that award to Charlotte. And Charlotte is somebody who she quietly gets on with stuff Charlotte Broughton, and actually is an individual who really stood out, in particular in wave 1, when she was the matron for the specialist surgery, Freedom Speak Up Garden, but she was going towards with Lawrence to do, sort of give support really from an emotional and psychological perspective, and helping him do debrief. She was going out to homes and screening, helping swabbing and screening patients who couldn't get into get on site to be able to get screened. And actually helping out some of the other wards as well. She's done a phenomenal job, and it was very worthy of her getting that credit. So that was lovely. The other bits around that day was we had Teresa Chin, who's our wee nurses. She's a social media nurse guru, actually, big time, and really talked about the social media's here to stay, clearly, and we've just got to be able to use it in the right way. And but she did actually give her account of working in a care home during the pandemic, and that was quite emotionally hitting, actually, with us, because it was quite harrowing, the experience that she did give. Clearly, going back to the deaths that they'd experienced, and but we had some really good discussion around that, obviously from my nurse's experience during that as well. So that was quite powerful. And then Trixie came in from the maternity side, because we had to obviously couldn't leave out the midwives, and she's a national guru on the continuity of care. She works for Jackie Dunkley Bent, who's Chief Midwifery Officer for England, and she gave a really good presentation, which again, you didn't have to be a midwife for her chat to resonate. It resonated with everybody about the quality of care for our patients, and for the women and their babies. So that was again quite a powerful chat, actually. And the brilliant thing, all of these, can go into on a link. If any of you want to watch them, you can do that. But huge pride, I have to say. You know, I mean, it's been an exceptional year, and I think we managed to reflect on that really well on that Friday, and the speakers that we had, and everybody went away with such a buzz. It was brilliant, and Twitter was going mad on that Friday night evening. It was it was hysterical. But just lovely. Everyone was saying how fantastic it was. So thanks, Suzanne, for being able to chat about it and reflect on it. It was super.
Thank you. Jane.
Yeah, thank you. I was just going to say that as a nurse myself and chair of the quality committee, I've dipped in and out of it, and it was really good. So well done. A really good event, and I think being able to do it, as you say, Andrea, quite a challenge to do it virtually. But I think being able to access it and dip in and out of it for me was really helpful. So in a way, there are advantages too, aren't there? That I can now revisit it if you can't be there. You can actually do it. So I think there's positives out of that. I think, which actually means that you've got an ongoing legacy there, which is great. So so thanks very much. From my point of view, it was an excellent day.
Thanks, Jane.
I'm also minded that Chris put in the chat, you know, what non-executives have been missing as well through not being on site. And I think, you know, when we do our away day, we're going to kind of reconnect on that and say, how do we best go forward as a team, having had this 14-month or so dislocation period, really. Although, as we all know, you know, working virtually has its advantages as well. In terms of the amount of things, as Jane's just said, that you can dip in and out of, and etc., without lots of travel. So good. Sal, could you take an action, please? Because I think what we've done is we've made Suzanne's report, particularly the risk-based report, sort of very central to these board meetings, but we haven't given it enough time in the agenda.
Yeah.
So I think we need to relook at that now, because we've given it the traditional time in the agenda rather than the time it deserves now, given its depth.
Of course.
Okay, thank you. Okay, we're now going to move on to the quality and safety agenda, and we're going to move to the quality report. And I'm going to go to Jane first to kind of highlight the assurance that the quality of care committee has taken from this report. Thanks.
Thank you. Yes, I think I'd just like to say that I think that your report, Suzanne, did pick up the main areas that we discussed. So thank you for that. I think your, as we said earlier, I think your report really does pick up the pertinent points. So I think that was really helpful. At the quality committee, one of the things we did reflect on, which isn't actually in the quality report, is actually relating to the performance report, is around the demands for the service and the challenges in restarting the service with the waiting lists and elective, while we still have a lot of unscheduled people, you know, people coming to the emergency department with concerns, walking in with concerns. So we did reflect from a quality point of view, that's a key challenge for us going forward, which we can pick up in the performance report. And from the quality report, I think Andrew will talk to the detail, but I think we're doing very well with our medicine safety, and we've been quite ambitious in actually giving ourselves an even higher target in reducing harm from medicine safety incidents. So I think that's a really positive thing. With infection control, although we haven't hit all our targets, we have benchmarked very well against our peers and nationally, and we've had some very positive feedback from NHS England. So although it is disappointing that we haven't, I think given we've been in a national pandemic, I think we have to accept that it has been a very, very challenging time. But obviously it's an area that the committee keeps a focus on, and we actually have, for the board to know, we actually do have a clear focus on this as part of a board assurance framework. So we do have a board assurance framework that is just dedicated to infection prevention and control, which we look at every meeting. With mortality, we accept that we need to review those deaths that have occurred for people under our care, and we have got some backlog in that, but we are recruiting into those roles. But the medical examiners team are doing some absolutely sterling work in actually dealing and linking with families, which I think given problems we've had with visiting, I think has been absolutely fundamental to helping people understand what may have happened to a relative that they've lost due to COVID or another illness. We've also had some really good progress on falls, and that's really positive because it was an area that we were concerned about, but I think we've done some really good work on that. With regard to patient experience, we wanted to have some more rich data at the committee, and it's really good now because we've got the text messaging service, which has just started, and that's allowing us to get some really rich information around feedback, comments in real time about what people are experiencing. And we're going to build on that going forward in the committee because it's an area we really want to focus on. So that's really important. And finally, on maternity, we in the closed session of the board talked about the serious incidents and the need for us to have an open view of anything that's happened within maternity, particularly under the Ockenden requirements. And that's something that we take very seriously at the Equality Committee. And we will have a detailed report on that in the closed section of the board at the next meeting. Thank you.
Thank you, Jane. So hand over to Andrea. Obviously, you can take the report as read, but take us through anything you want to focus on, please.
Yeah, great. Thank you. Thank you, Andy. So just to pick up on this report does cover March data and also April. And at the time of the report being written, because the way that the calendar month falls with committees, some of the data you'll see in the report it isn't there present for April, but will be obviously covered up in the next subsequent report that we have going to committee next time. But the key things really, just to build on what Jane has said, I think, you know, COVID this last year has been a real challenge around the infection prevention control bits, particularly around the infections that we've seen, and that's just come with the challenges that COVID as an infection has presented to us, and actually around the harms as well, with the pressure damage and also the VTE too. But actually, although, I mean, we set ambitious targets around all of these, around our quality priorities, and that's right and proper. Although it's been a challenge to meet those in this last coming year, particularly around the infections and the harms. You know, as Jane's alluded to, we're in the top quarter when we've benchmarked, particularly around the infections, with other trusts, with our peers nationally. We are in the top quarter as the lowest around infections, and that's absolutely, you know, brilliant to see. And again, has given us you know, sort of a bit of a boost actually that we're not doing as bad as as you may think, but actually it's positive, and we're continuing to bang that drum. And actually the April data has looked really good in that we've had no Klebsiella infections, no Pseudomonas infections, no hospital acquired COVID infections, no MRSA. And our E. coli infections have really reduced quite significantly. So again, I think that it's indicative of us coming out of COVID. Obviously, there's huge pressures on ITU, which I think, you know, has contributed to the increase in infections that we have seen. But great to see that. And then around the harms, again, our pressure damage has reduced as well, with category 2 pressure ulcers reducing and tissue injuries reducing as well on previous months. So that's super to see. The only other bit I'd like to bring out is around maternity and the Ockenden requirements, obviously progressing against the immediate and essential actions that we're required to do. And just to give a quick synopsis is that we're making good progress against those 7 immediate and essential actions around our recruitment of midwives. We've got a 7-day service now with our obstetricians, and also the fetal wellbeing training we're on track with, and also we're looking at our formal assessments now, because with every touch point of a woman who comes to our service who has a contact with a midwife or a clinician, there needs to be a risk assessment done around that. Something we haven't been doing before. We've only done it on particular key points of a woman's journey, but every touch point now has to have a risk assessment. So we're building on that. And the last bit to state is with the CNST. We're making good progress against that. That submission is due mid-July, and and we're just working towards that, doing the final bits towards that that submission, and obviously we will be able to look to sign that off, Andy, again at one of the outer committee board calls that we have. So I think that's really probably, I guess Jane said quite a lot of it actually to mention. There's a bit about SSIs, and David, I don't know if you want to just pick up on that around the surgical site infections, obviously around the reporting that we're doing. We're doing statutory reporting, but obviously we're improving, aren't we, on our other SSIs. Is there anything you want to pick up on that?
No, I think, I mean, there's been a huge amount of work done on SSIs. I mean, Anna's leading that with Shashi in the division. And I think we're just starting to see some changes. If you look at the fracture neck of femur and even the cesarean section, it's starting, I think, to show the direction of travel. There is a big webinar on surgical site infections, which has been put on for the whole trust, that Anna's been organising. And there's just a huge amount of work that's going on there. And the only other thing I would, a bit like you've said, Andrea, I mean, I think Suzanne's report has highlighted some really good things to look at in this report, and Jane, your summary was covered most things. I think the one that both Suzanne and Jane mentioned was the structured judgment reviews, but also how brilliant the medical examiner office is doing, and the enthusiasm within that office to really get that in the right place. And there is a business case which we're going to take to tech quite shortly, and I think with a bit more capacity and resource, they now have the enthusiasm, the drive, and with the right tools, they'll be able to sort that out, and it's and it will be great. So I think that's all I've got to add.
Great.
Okay. Jane.
Thank you. I was just going to add a little bit to the maternity update, in that I was really pleased to be able to take part in this actual on the ground safety walk around, obviously taking all the necessary precautions at the end of March. We have started to actually walk around with a tea trolley with cakes, safely wrapped, individual, according to the guidelines, and actually talk to staff, any member of staff that's on the unit, on anywhere in the unit, just if they have any concerns. And that was actually quite a rich discussion, and to be able to actually do that was brilliant. And that's part of the role of my role as maternity safety champion for the board. And we also now have very well established monthly meetings, don't we, Andrea? Which are really rich. So just to really update the board on that as well.
Yeah, that just to reflect on that walk around, we had some really good discussions with the teams, and we did the full tour of maternity and also went to NICU as well. Great engagement. And actually some of the stuff that they'd highlight issues wise, it's you said we did, we've already actioned. So it's brilliant to have, again, that feedback loop for them on what they'd raised.
And I think just to widen that point before I bring Suzanne in is the importance of bringing back, as soon as we can safely do so, the walkarounds program with execs and non-execs. Clearly it's working well in maternity because that's been a point of focus. Because I think, you know, our staff on the ground like to see people and like to tell people what's going on, and just sometimes we can short circuit things, can't we, and get things, small things that are small irritants that would never come up, just fixed. So I think that's perhaps, Sal, you could chat to Andrea about doing that safely within the obviously IPC guidelines. Suzanne.
Thanks, Andy, and thanks, Andrew and David, for it's a really good report. The only thing I was going to give you an opportunity to share or reflect on was the conversation we had earlier in the week about data around COVID hospital-acquired COVID deaths, and clearly, as the report describes, if that's identified through any other kind of process, that automatically becomes an SJR and we'll get that level of scrutiny. But what we don't currently do is report that data in a more formal way. And I know we've had a conversation about doing that, which I think will be useful for us.
Yeah, thank you, Suzanne. Any questions on anything that's in the quality report for Andrea or David? Just to say a thank you really to the 4 non-executives who are on the quality committee, because I know that that is a huge commitment with many, many pages to go through in detail. And you know, we do as a board gain assurance from all your work at that level. So thank you for that. Right, in which case we'll then move on to the quality of care minutes. Jane, you've got those first. Anything you wanted to highlight?
Nothing I need to highlight, thank you. They were accepted as an accurate record at the meeting. I don't have anything further unless anybody has any questions.
Okay. Just watching for hands. Okay, thank you. And you've now got your annual report. So we don't let you off the hook lightly here today.
No, that's all right. So this report summarises the work of the committee for 2021 up until the end of March. And you will notice that at certain times we had some lighter meetings to reflect the operational demands the service was under during the COVID surges. But I think hopefully you are assured that we maintained our focus very much on the quality and the experience of people using our service. We are now trying to get back to matters a bit more akin to normal, with our divisional reports and our divisional directors attending the meeting, with our annual summary reports being presented. There are a number in the report that you can see. As I said before, we have a key focus on quality and safety. The performance report, our Chief Operating Officer has worked hard to actually make sure that he pulls out the quality patient experience points that are really pertinent to the quality committee. So he talks to those at the committee, and that's been a recent development over the last 6 months or so, and is a reporting development. That's been a really positive thing. We've also obviously looked at our quality priorities and the annual quality statement. So I don't have anything to say. I'll assume that the report is read. If anybody has any particular areas they want to ask about, myself, Andrew, or David would be very happy to take any questions.
Okay, thank you, Jane. A very comprehensive report. I thought very, very good. Covers the ground. Just I had one question. I think we've touched on it, Andrea, before, but the kind of the increase in, you know, and the non-meeting of sort of the E. coli, the MRSA, I can't pronounce some of them. Are they pandemic related, or?
Yeah, so this was around the bacteremias and actually seeing the spike in those particular infections, Andy. I mean, it's been seen nationally actually, so we're not sort of an outlier with that, but it's very much coincided with the increase in ITU capacity. Obviously, we went from our 1 area to 3 areas. We tripled our ITU patients, and with that comes obviously lots of lines with those patients, and obviously the proning of those patients, because particularly around there was a Pseudomonas and Klebsiella were the ones that did really spike. Is that, you know, they're very much respiratory type bacteria that with patients proning and obviously increased secretions coming out, which you need to do for the COVID patients, obviously that then, you know, led to some of the lines being contaminated. A real challenge, and one that's, you know, was seen nationally, and obviously we have seen, since we've retracted now with the number of ITU patients, that number has gone down. So yes, to answer your question shortly, yes, it definitely was a COVID influence.
And I think possibly the only other thing that drew my eye was the kind of 4 never events compared to 1 the previous year. And clearly, you know, 1 never event is too many. You know, is there any sort of pattern, or were they 4 very disparate never events?
Yeah, 3 of them were associated again with COVID, around COVID patients that with the non-invasive ventilation, and the obviously the demand that was being placed on us within our wards and our side rooms, and those particular cases was they were being nursed in side rooms, and the non-invasive ventilation come off. So we've put really rigorous controls in since those incidents have happened now. I mean, anybody who's on non-invasive ventilation now in a side room has a one-to-one per, just making sure that the mask remains on.
Okay, thank you. Anything else on the annual report from anybody? Okay, in which case, Jane, you're still on the hook. Sorry, Chris.
My hand up here, so it's just battling with some technology issues. Sorry, can you hear me now?
Yep, I can hear you.
Technology issues here, sorry. So I think just sort of reflecting on that whole report, Andrea, it does show that just how much is still being addressed by the hospital. And I think, Jane's point, you mentioned about how we had to cope during COVID. It was a fundamental change, wasn't it, in terms of the meeting, the way they were restructured, shorter, but still focusing on the key, North Star objective. And I thought that was good. I just wonder on reflection whether we can still learn from that, because we do have a huge amount at quality. It's always a struggle, isn't it? And I just wonder whether we can learn from that sort of sleeker governance. So, have the regulatory requirements in there. But I just sort of reflecting on that. It's hidden in there for me. It's sort of like it was a fundamental change for us, and I just wonder whether we can learn from that in moving forward. And it'd be awful to slip back into our old ways again, in the sense of sometimes you can be overwhelmed. And I think we had it really nicely focused. And I worry about when we come into performance about the walk-in attendees. There's things creeping up again that happened pre-COVID. And I just wonder whether we can learn from the good things that we did to especially around the governance and making it sharper in terms of the way we did things. I don't know, it's just a reflection. I don't know whether you've got any comments on that at all, Jane or Andrea.
Yeah, I mean, I think you're right. I think we, particularly at March, April, and May, we had a monthly QCC, didn't we? And it was a reduced meeting, and we did really. So I think you are right, Chris. I think there is stuff we can definitely pull out of that. Very conscious there's a huge of information that we do cover at QCC, and Jane and I have just lastly spoken about that and with the last committee. And I think you're right. We do need to make it more streamlined. So I think it's a really good point. We should again.
It's very. I mean, the documents are so detailed, aren't they? And they're brilliant in that sense. They are so comprehensive. I think they've improved hugely. But I guess now we almost got the opposite, haven't we? It's around sort of less is more sometimes, and really focusing on the key issues. I think we are. It's a lot of work for everybody, isn't it? And I just wonder if we can learn from that. That's all.
Yeah.
Neil.
Yeah, look, I haven't attended Quality Committee, so I'm just going to ask a kind of assurance question, I think, on behalf of the board as a whole. There were lots of reasons why this was an exceptional year, is the gist of the annual report. And we all know and understand that, and the governance arrangements we changed are all part of that. But I guess from an assurance point of view, we should be, fingers crossed, reverting to type and going to a normal or a more normal or near normal year the next year. So the one point I wanted to pick up was kind of learning from deaths. There's a sense there in that segment of the report that we are still picking up on some of the reviews. What assurance can you provide me, us, the rest of the board, that we'll get back to reviewing and learning from those experiences more quickly as we would have done in a normal performance year?
David, do you want to pick up on that?
Yeah, shall I? I think it's a really good point, Neil, and I think Jane picked that up in her summary, and also Suzanne picked it up in her summary as well. And I think if you look pre-COVID, our response on the structured judgment reviews was too slow. I think that the assurance I'll give you is that I think that during COVID, the medical examiner's office has now been put into place, and it's done an absolutely amazing job. I mean, Jane mentioned about the liaison with the bereaved families, which contacted 85% of all the bereaved families within a short space of time and talked to them was to end. And I think my assurance comes from the enthusiasm that that team are giving, that they want to get it all right. And they do need a bit more resource, and we've got a paper that we were discussing at execs only the other day, which needs to go to tech to put that resources in, and that's really to make time for the clinicians to do this really important piece of work. But I think there's an understanding of what's needed amongst the executives, Neil.
Thank you, David.
Thank you.
Thanks, Neil. Okay, I'm going to move on now to Jane. Your terms of reference are presented here. Are there any changes in them? There wasn't any highlighted changes, or are they as per they were before?
The only change that I'm aware of is on page 4, which was just around quorum, and the fact that it did originally say 2 executives and 1 executive director, but I just wanted clarity that it's 2 executives and 2 non-executive directors, that's including the chair. Otherwise, I felt like if I was there on my own, I didn't have another non-executive to support me, and that wouldn't be adequate. So yeah, that's the only change that I requested. Unless, Andrea, there's anything else, I'm not aware of any other change.
It was just adding in James as the coup as well, wasn't it? On the because he'd been missed off. That was the only one.
Yeah, he was missed off inadvertently. Yes.
Yeah.
So so yes, but apart from that, they're as they were.
All right, and so the general point, I think, Sal, for any of these that come to board, that they should be highlighted. The changes should be highlighted. Do a track changes on them so that we know what's, because we don't flog through all the other stuff then. So if the changes are put in track changes, then we can all see, our eyes will be drawn to the changes.
Okay, yeah.
Okay, thank you. Do we need to approve those terms of reference, Sal? Yeah, okay. So can we approve the new quality committee terms of reference, please? Thank you. And we're going to move on now to the 7-day hospital services programme, and this is a biannual report. We see this regularly. David, are you going to lead on this one?
Yeah. So just to give a bit of background to this, because people may have forgotten where this came from. So this was an initiative brought in by Sir Bruce Keogh, I think in 2016, and as everyone remembers, he was the medical director for the NHS up until 2018. And actually, he brought in 10 standards, and this report is about the 10 standards. And when they were first brought in, they did receive quite a lot of pushback from organisations. But I think when you look at it, they become more and more relevant when we look at it. And this is about delivering services to our inpatients 7 days a week. Now, the standards we had to meet was the 4 priority standards, which you can see, which are 2, 5, 6, and 8. And you can see our progress with there. You can see that during COVID, time to first consultant, there was a period when we dipped down to 85%, but we're now back up to compliance for that. And in fact, standard 8, which was ongoing review by consultants, I mean, a lot of the work we did during COVID, we saw the benefit from making sure that rotas were completed to review patients on a very regular point of view through surge rotas and making sure that we had consultant capacity, particularly during the weekends. So we're doing well on those 4 priority standards, and the report also outlines the other 6 standards. And I would say that they are really important as well. And I think in every area we're progressing, and we can see how the plans around Cerner, our work with mental health and Surrey and Borders, and our work on communication with patients through the respect form or through MDTs is evident in all those standards. So I'm happy to take questions, but I think it is worth making the report that they are they are much more relevant, or they appear more relevant than people thought they were some time ago. Aaron.
Thanks, David. Just a quick question about Standard 3, MDT review of emergency inpatients within 14 hours. Is when that specifies MDT review, does that mean on group, as in collectively, or does that mean members of the MDT in isolation? Because if it's the latter, I would have thought that that's happening quite well already. Maybe if I'm mistaken, but if it's the former, I can understand why.
Yeah,
that might be more difficult to achieve.
I think it's a combination of things. So I think a big bit of that is the reconciliation of medicines as well, and I think it is. You're right that the definition in some of these things wasn't clear when they were first articulated. But I think that where we've taken this is making sure that decision making is made in an MTD basis when you need to make that. So a lot of work that we put in place on this was decision making around urgent surgery and making sure that all the people were involved. And actually during COVID, palliative care and the ITU spent quite a lot of time in doing this. So you're right that it is, some of these standards are hard to implement for the full 24 hours, but and some of them are slightly vague. But I think the ethos is right. I think the ethos is right for these.
Suzanne?
Thanks, David. I mean, it's a sort of general observation, and it may not be useful to make a general observation, so do say, but looking at the standards generally, we seem to meet them better at the weekend. And my recollection of these coming in was because there was a perception that weekend care was not as good as weekday care, and it's just. And do you think that is related to the surge rotas and the way we organised ourselves? Because obviously it's the data at the back end of the year is covers that period.
Yeah.
Or
Well,
is it just?
Well, I think, and we discussed this, I think quite a while ago, and I think it's because there's a clarity of role at the weekend, which is sometimes lost during the weekday. So that what tends to happen sometimes during the weekday is that people have multiple roles.
Yeah.
And therefore their attention to a role may be diverted by another role that they're doing, and that's what you get at the weekend. So the consultants, they're based on the ward, they're based in the operating theatre, they're based wherever they're meant to be, and I think there's a learning there, Suzanne. I think
Well,
you're
that's
right,
kind of what.
which is we have to define ourselves so people do know which role they're meant to be doing at a time, and it's not a mixture of roles that they then have to juggle.
Yeah, because all the other things we ask them to do predominantly happen in the week. Governance activities, just as one example. No, I thought it was useful to draw that out. Thank you, David.
Marcin?
Thank you, Chairman. David, just a question. I know it says they're not required to report nationally, but does that mean we don't have any sense of benchmark of where we stand on these standards versus other trusts? Is achieving 4 out of 10 a good performance or an average performance? And do you think by next year we'll have achieved against all 10? Thank you. Sorry, I know I always ask the hard ones.
No, they're really good questions, and I think there is benchmarking about the 4 priority standards, but I don't think there is on the others. If you ask me, I suppose my introduction, Marcin, was to say actually the 10 standards, and as I said, Bruce Keogh, he had a lot of kickback from the medical profession. I think they are good. I think they are. They show how we should organise ourselves, and I suppose as a board, you should be asking that we should deliver those. And I think in most of those other 6, that a lot of it is about communication. So the standard 3, Aaron, you were talking about, a medicines reconciliation. Well, the shared care record and the CERN implementation is going to really help with that. The work around the respect and the work that we're doing with palliative care and the hospice is going to help with some of that MDT decision making as well. So I think we should have an ambition that we are compliant at the end of next year, and I think we're making good progress. But there's not much push from above in doing this work at the moment, I don't think.
I think that's excellent, David, and I would endorse that we try to achieve compliance with all 10. They seem very, I'm a non-clinician, but they seem everything you would want as a patient.
Yeah.
Thank you very much.
David, just one question from me. Did these originally cover maternity? Because I noticed under Ockenden, we're just doing this for consultant cover all the time in maternity. And if it didn't cover maternity, why not?
Yeah, I don't think it did actually. And there was a kind of separate parallel path. I mean, Andrew, you may know about this, but there was at the time depending on how many births an organisation did, defined how much cover they should give in terms of consultant cover. And I remember at the time, Suzanne, we had lots and lots of discussions saying, what, just so you deliver half as number of babies, you don't have to be quite as safe as if you deliver that, so there was a bit, and this is where the kickback that Bruce Keogh had was because these standards are, in terms of personnel and workforce, are quite hard to achieve in some areas. And they were felt to be, I think, impossible in maternity at that stage. Ockenden is now pushing all these things to the forefront. Is that your recollection, Suzanne? About
Definitely. The standards for obstetric cover, and it predominantly relates to the labour ward. So it always got sort of watered down with the opportunity to have midwife-led units and so on and so forth, because the standards would be different. And we always felt that absolutely should be, really 100% on the floor obstetric cover. But you got into a case where it just, I mean, the challenge was then reflected back in the finances. It was impossible to because it would just mean your service was just unaffordable, which was why these sort of proxy standards were brought in. Really, they were not the right standards. So we're heading in the right direction now, I would say. But I think you raise a really important point, Andy.
Thank you. And I think I saw from the report elsewhere that we've now, through locums, we're actually meeting that in maternity, aren't we?
Yeah, and I think it is really important, because it's, when you need the assistance, you need it, don't you?
Absolutely.
You don't need to be waiting for someone to get in the car and travel 15 minutes to get to you. So.
Okay, thank you. Anything else on the 7-day services program? I thought it was a good debate on that, and excellent question, Marcin, by the way. Right. In which case we then move on to the volunteers annual report, Andrea, and I think it's a very different one, isn't it? We've had to change the age profile of our volunteers in many ways.
We have. I think this report is very reflective, really, on the year that we've had with COVID, and actually, again, due to the age range of our volunteers, not a lot have been able to become on site. But positives that have been there are that we have recruited new volunteers, of a younger age group, who, following being risk assessed, that were able to come on site and have been in the last year, and actually have really helped us with our, I'd like to say, really the infection prevention and control strategy, because we've had really restricted visiting in place that supported that strategy in order to reduce our footfall, as you know, which has really helped with our fantastic COVID transmission numbers being low. But it came at a price, and it came at a price with relatives not being in touch with their loved ones in hospital and not being able to be kept informed. And what the volunteers have been able to do during this last year, which does come out in the report, is have been that connection of being able to go to the wards with the technology, with the iPads, visit the patients and link them up with their loved ones and help them with that, which has been a huge support. Actually, they've also lastly been helping with our IPC strategy. We've got very strict control points at our entrances in our hospitals, where you have to walk into it's a control stream, really, where you have to put alcohol gel on your hands, put a mask on, and then look into a thermal camera to take your temperature. And if everything's okay, then you're permitted to come in. And the volunteers have now are positioned there in those entrances to help in the daytime to help patients who are coming in for appointments, and now visitors because we've relaxed our visiting to help them as well, just to navigate through that process, and that's been again very welcomed, and has released our staff who were providing scrutiny over those areas to go back to the wards and the key, obviously their key roles that they were doing. And the latter thing that the volunteers are getting involved in is because we've relaxed in the last week or so, relaxed our visiting in line with the national roadmap, is that they're helping with booking appointments for relatives to come and visit their loved ones. So rather than, we want to do this in a staggered way because of the footfall, what we don't want is, by relaxing our visiting, is all visitors coming in at once, but having a staggered approach. And the volunteers, headed up by Joanne, who is our new volunteer manager, we've recruited from Heathrow. She was made redundant from Heathrow, and golly, she's just been absolutely brilliant. Joined us in December and has really hit the road running, but she's seen that actually the volunteers could really help with this, and there's a group of volunteers with a dedicated phone line that relatives can phone into to book an appointment to come up to the wards and see their loved one, and it's staggered and it's very controlled. It's gone down so well. I was getting feedback from the ward managers yesterday. They're absolutely said it's been phenomenal. It's really phenomenal, and super support to them. So going really well. So it's a mix. It's a bit of a mixed bag. The volunteers have not been able to be on site as much as they would like to, but those that have really supported us exceptionally well. And obviously we are looking forward to them returning. You know, as we go along and the situation is reviewed as well. I know they're really keen to do that. But happy to take any questions around any of this. Thank you.
Sorry, the hound of the Baskervilles is going off here. Jane.
Thank you. It was just really that we received this report also at Quality of Care, and Joanne presented it, and I would absolutely agree with Andrea. Her enthusiasm comes through, and it's such a great story to have recruited her from a customer facing role, but actually she's bringing those skills to our trust, which is brilliant. And one of the things we did ask at Quality Committee was around, actually, I think it's absolutely brilliant that the volunteers are helping coordinate the visitors, but it actually can be maybe a little bit of a challenge at times. So it's just being mindful of the support we need to give the volunteers. And she's very aware of that, because sometimes people don't want to be told they can't visit on a Monday or a Wednesday or whatever day, because obviously we're having to manage visitors. So it was just about assuring the board that, you know, obviously that has been considered, so the volunteers are also supported in their role, because they are so valuable to us. So yeah, thanks very much to all of the volunteers, and the Quality Committee really wanted to extend their thanks, as I'm sure the board will too. So
yeah, and it's absolutely, I was delighted to see so many of old faces coming back in, actually, and seeing them at the entrance to the hospitals again, and they're clearly really happy to be back as well. So that's very good. Marcine.
Thank you, Chairman. I just wanted to put an assurance piece on. I was going to mention later under people, but we did ask Andrea to do an assessment of internal audit recommendation on the quality of our volunteer program. And I was pleased to say that Andrea did that, and we had a good report. We are meeting most of the best practices, a couple areas to improve on, and they've got an improvement program, and it sounds like Joanne is the right person to take that forward. But just assurance to the board that not only is this, you know, do we have a great volunteer service, which is vital. I started my life as a hospital volunteer, but that we do it right and we do it proper. And so I'm pleased about that as an assurance piece. And will be telling the audit committee at their next meeting the results. Thank you.
Thank you, Marcine. That's very helpful. Andrew?
Sorry, mic on. Yes, Andrew, that's really interesting. I just wondered again, it's the learning point, because here's another example of someone who's come from a customer focused organisation in the private sector, and of course Sean, who we spent time with, who was involved in running aircraft, customer focused, and his insights as a patient in your hospital. I just wonder what learning there is, because part of the challenges in the NHS is how the NHS gets a real understanding of customers from that point of view. So it's the learning question, and how that's been captured, and what the lessons might be elsewhere, and how a hospital and other parts of the NHS embrace people who come from other sectors rather than just the public sector.
Yeah, I mean, you make a really good point. You make a really good point. And Joanne, I mean, she only joined us in December, but the impact she's had has been huge. And it's her ability to, well, it's thinking outside the box, but you're right, that customer service bit is actually, how do we get around this problem? How can I, with my team, be able to support and solve that? I think has been really pivotal. So it's a really good point you make. Yeah, again, another example that we should really draw upon. I agree.
And I think perhaps, you know, she should write down her experiences, because I do tell the induction course every time, you know, the first few months when you arrive from another role is critical, because otherwise, you know, the system will get you and you'll stop seeing things that you see in those first few months. And actually encouraging people to kind of write down their experiences and benefit from those experiences over those first 3 to 6 months, I think is really, really critical. So,
I mean, just a final thought on that, Andy, because you sort of wondered, one of the things I find encouraging about this board is that it's a bit like earlier with William and Ralph and things, listening to people who are on the front edge of, and we did it with midwife, didn't we? Is really, really important. And you sort of do wonder if the micro is going to speak to the macro, whether one or two of these people are the right people and would feel confident to come at some point, have a space to speak to the board, coming from an outside culture and another view of the world, you know, what they've seen in the culture, because there's real learning and opportunity in all of that. But sometimes the dialogue doesn't happen, and the public sector seems to be so often full of processes and think it's the only way of doing things, where those of us who've worked in other worlds know that it's not the only way of doing things, actually. And it's how you open up that real informed transformational discussion.
I think, Andrew, can we give you that to take away? I'm going to bring David in a second, just to have a think about how we can better capture people's experiences in those first few months and make the most. And Ralph was a great example, wasn't he? Of what he's brought, and Joanne is another one. David.
Well, it's just to say that, Andrew, I think the point you're making as well about the barrier that exists between the public and the public sector and other sectors, where we don't let people in from the public sector because we don't think they're lined up for some reason, is just such a tragedy, and we've got to break that down. And I think COVID, what you're pointing to is right. This, you know, the people who've come and worked in our organisation from other industries have just got immense skills in areas which are the most important skills when you're dealing with people, and we've got to really make sure we kind of open our thoughts to people from many other areas who can fulfill these roles. And I know Louise is doing loads of work in recruiting people from these into what were care roles before, and only recruiting from a certain set of people with a certain set of criteria that what the public sector thought would fit. So it's a really, really important piece that I think you're mentioning, Andrew.
Thanks, David.
If I was muted. Take one more question on this and then we've got to move on. So Jane?
Just to really reinforce that, I volunteered at the vaccination hub, and I worked mostly, actually, my support were cabin crew who were either furloughed and their skills were exceptional with the public, and many of them, interestingly, reflected on how much they were enjoying the experience, the opportunity, and also how much they wanted to join the trust, and that they hadn't thought about a career in health before. But the challenges were around those transferable skills and some of the gateways that they had to go through to transfer. So I think absolutely the points you made, Lord Mawson, are really pertinent to how we can actually, because they may not necessarily have had experience of caring directly for people, but as in a clinical side, but actually from a caring for people, they were brilliant. So I think that's a really good point, and I'm just supporting what we're saying, that we really need to think about that, because the people I work with were brilliant.
And I think final one from me, Andrea, is I was just thinking about some of the organisations that sprang up to support us, like Nourish Our Nurses, have got a heap of volunteers in, and as they've kind of stopped doing what they're doing now, I was wondering if we could contact them and tap into that and maybe get some more kind of younger as well, volunteers from them, because there were some really interesting and very dedicated people that were on that. I mean, you never know, we might get the Countess of Wessex and the Lord Lieutenant that way, you know.
Indeed. Yeah, absolutely can do that. I think just to say that from a staff perspective as well, with the cabin crew, we've had a successful recruitment of some of those individuals coming in to be healthcare support workers who are now going to be going on to do their nurse training. I think that's just, again, just fantastic. It's a good news story, isn't it? Brilliant.
So thank you for that, Andrea. Very, very good to see the volunteers back. Really fantastic to see the volunteers back. Okay, so we'll now move on to the performance section of the report. And we've got the performance report first. We're going to do it slightly differently given that James isn't here. We'll obviously take that as read, but I'm going to ask the chairs of the two committees that it comes to, modern healthcare and quality, just to give a sense of the assurance that you've got around this particular report, so that other colleagues can hear it. So perhaps, Merrick, would you like to kick off with the modern healthcare?
Obviously, these reports cover the period as we transition from a still incredibly busy period of time within COVID, and then as we plan to come out of it. And the reports and the debates are focused on both. I think in particular on the performance side in recent months, we focused on the iteration of the operational team, recognizing that things that they were trialing weren't working as well as they needed to, fast iterate on that and improve performance coming through. And I think that is as much as one can look for working in clearly uncharted times and conditions. And we've obtained a lot of assurance through our deep questioning of that, and have seen the performance improvements. We've also focused on understanding how metrics have worked in the past for us in a certain context, but clearly in the COVID don't work for us so well. An example of that being, of course, utilisation of theatres, where the utilisation measure, as we dealt and questioned in more detail, was the utilisation of the theatres that were open rather than the utilisation of theatres in total. That's just one example. But we, as I say, we have got good assurance that the operational performance has been maximised within what's been the constraints that we've operated under, and where there have been times where it's not maximised, we've understood the learnings from it and quickly iterated to get the improvements.
Thank you, Merrick. Thank you. Jane?
Thank you. We spent quite a bit of time on this, as we normally do at Quality Committee, because we recognise that, you know, performance is really important in relation to the experience and quality. Our main areas that we sought assurance on was that we were concerned that there'd been an increase in footfall through the emergency departments, and that is a massive demand. And so we were seeking assurance around infection control, so there are clean areas and obviously areas where you may be positive for COVID, and we were provided with adequate assurance around that. We were concerned about why there was an increase in demand, and actually I think that's very complex, and I don't think we could answer that in the committee, but obviously public are beginning to come back in through the door. And the other thing we really focused on was the elective, the waiting lists, and the fact that we needed assurance that that people were clinically assessed to make sure that they were appropriately waiting and being seen according to need and priority. And we received assurance around that. We were pleased that some of the work on endoscopy, waiting lists, we still have some concerns around ophthalmology, because we know it's quite a lot of people waiting still for that service. So that's something we are keeping an eye on from a quality point of view. But we also recognise that the service has been under massive demands, as Merrick has just said, and has done sterling work really to maintain the quality service. And I think now our focus is on trying to get things back to normal, and looking at those people that have been waiting quite some time now for services, accepting that we wouldn't want them to wait as long as that, because that's not what any of us would wish. But unfortunately, due to pandemic, that has been the situation.
Thank you, Jane. Suzanne, have you got any comments to make? Build on those?
No, I think my non-executive colleagues have done a fantastic job, actually. This is James's report, and clearly I would never do justice to James's report, and he will be in contact with you all to check in on how we've done. But I mean, the only thing I would say is that so with regard to urgent care, David it has rightly said that for us to get a view, we really need to get the detailed data. Where are our patients coming from? You know, what is the transition from UTC through to the ED department, etc. So we're going to do that bit of work, and we've also been in conversation with Jack at Northwest Surrey around how can we understand what the implications are on primary care? And there are quite a few strategic pieces of work being done to support primary care. For example, an e-hub is in development and design, which will be around call handling, possibly a different kind of triage, because I think what we're not clear about and what some of our GP colleagues share with us is that they are responding to a huge increase in virtual demand and online consultations, which is potentially diminishing their ability to respond to the need for face-to-face. And what they're not clear about, which I think is perfectly understandable, is the extent to which the triage prior to that enables them to actually see the patients they really need to see face-to-face, and that the triage is ensuring that those on an online consultation could actually be managed by non-medical professionals and others. So I think there's quite a bit of work to do. So you point to the complexity, Jane, which I think is really helpful. And of course, we will continue to work up the model of care as the assessment unit comes on stream. That's a big opportunity for us. So with or without the ED refurbishment, we should definitely see some benefit from that in terms of our overall performance and flow within the trust, and the management of the infection prevention control of our non-elective take. So I think that's really important to say. I think what you can see in the report is that the data for urgent care actually looks a little bit better, but I would guard against that. I suspect it will look worse next month because the demand is really, it talks to 101% pre-COVID levels. On the data we had, I would estimate it's higher than that now. So I think that is a concern. I think with regard to elective care, James and the team are doing an absolutely extraordinary amount of work to reconfigure services in order to meet the requirements there for addressing the backlog, which is really important to do. And when I last looked at the summative position in terms of our elective care for April, in sum, we had achieved 104% activity on our baseline for 1920. So we are even beginning to address some of the backlog there, but clearly we need to go further and faster. And James has articulated within the report the new detailed standards that we're going to be required to meet. And I think in all domains we are moving in the right direction. And the fidelity on that information is actually really helpful for us all to be seeing and sharing. And he lists within the report the huge amount of things that are going on, particularly at Ashford, but actually also at St Peter's, to ensure that we've got the infrastructure to support that achievement. And we've got the, don't forget, and Simon will come to this, I'm sure, the elective recovery fund, which will give us an opportunity to, we're incentivised for all activity over 100%, and you can see the trajectories within the report that we've committed to in terms of our plan. So you can see we're already in the space of having opportunity to secure that additional income in terms of investment for this trust, alongside our the announcement of the planned care accelerator. So Surrey Heartlands is one of the systems that is benefiting from that, and there is a £10 million incentive fund coming from the centre that'll help us, where possible, go beyond 100% of activity. And we're just working up our plans to deliver on that. And I think, you know, the assurance, James does a good job of documenting the assurance against each standard, so that's there for you to see. So I won't be happy to take questions, and I'm sure my executive colleagues will help answer any of the detail that I can't.
Okay, thank you, Suzanne. Chris.
I'm really, I feel that, this gets better and better, this report, doesn't it, with James and the insight it provides. And, I know the referrals have been an issue, and it's not surprising given the theatre capacity has been in a state of flux. And, it is reassuring that we've got this capital investment and comprehensive set of actions against diagnostics, outpatients, cancer, etc. So I think that was all really good, and endoscopy was very encouraging. So I think it gives us great insight. One of the areas that I'm still bewildered by, Suzanne, I don't know whether you can answer this, was really around the the walk-in attendees, which is worrying. I mean, and David's right, we've got to get to the bottom of it in terms of triage and data analysis. But I wonder, is this something that's a phenomenon across the ICS? And I just wonder, there was the Think 111 initiative, whether there is something that the ICS can do generally to try and detract people from going direct to hospitals unless there's an absolute need, so that we sort of can do some triaging, if you like, for people generally, so they understand that you just don't go in there and hang around like they used to, because it was up 25% year on year. So I just wonder, has that pattern been seen around Royal Surrey and Frimley, do you know?
Yeah.
And are they doing similar actions to ourselves?
Yeah.
Is there anything as a system that we can be doing?
Yeah, thanks, Chris. I can see David to come in on the dip, but the answer to your first question is yes, absolutely. It's not actually just Surrey Heartlands; it's a national picture, and all trusts, and as I said, alongside primary care, are reporting huge increases in demand. Whether that and predominantly that is what you would refer to as walk-ins, what we would call minors activity. So our flow through the majors pathway is pretty consistent, actually. But I'll come to David because he'll have a good view on the data and the detail. David.
Yeah, no, I think you've covered it, that it does seem to be a national thing. And in fact, Royal Surrey had a greater impact before us on this increased workload. So they really were struggling with volumes in the Royal Surrey. And I suppose that's because they've got fewer walk-in centres and those kind of facilities around them. I think the point you make is a really, really good one, Chris, that the idea behind Think 111 is you redirect patients to what they need in areas which don't always lead to A&E. The problem is those areas aren't defined yet very well. So there's a bit of work to be done in terms of the primary care networks, in terms of the community offerings, but also internally as well in terms of hot clinics and access to clinics. And I think that the Think 111 narrative has started before the infrastructure is in place to help offload it in different places.
Thanks, David.
Thanks, David.
Very helpful. Aaron.
Thanks. Actually, I think Chris has partly asked the same question I was going to ask, but it's just around some of the detail around attendances in A&E, and the fact that it might be my crude assessment of it, but looking at the nadir, or the lowest kind of attendances in December, February, you would expect 4-hour performance and things to be better in that period, but it's the contrary. I was just wondering if there's any more that can be done to drill down into the reasoning behind things like that.
I can see David's going to come in and answer the question. So, so go ahead, David. Oh, we can't hear you. You must.
Sorry, it was going to happen today, wasn't it? I think if you look at the performance during the first wave, in fact, what you described absolutely happened. And in that time, we had a lot of capacity within the hospital. And actually performance in A&E was extremely good. I think that what's happening at the moment is two things. We are coming out of COVID, but the attendances and the admissions through A&E are rising, and we have a bigger difficulty in dealing with the workload coming through the organisation. So I think if you look at the report, Aaron, it details some of the work that James is leading, which is the Alliance 16 program, which is a really good system program, which ESIS have supported across the community, and that's looking at all the areas. And I think that the really good national piece of work is around the right to reside, which is, if people are in an area, what are they in an area to what's the need that's fulfilling that area. And if they don't need to be in that area, they need to be in an area which provides the need they have, and that's around the right to reside work. But there's some really good pieces of work in there which we're doing with the system to try and get the capacity right. And I think Suzanne will come in and say that we haven't got the capacity right in all the different bits of the system at the moment, or the capability along with the capacity to deal with that. And that's in all our bits. And we need to do that bit of work to get that right.
Yeah.
The other bit that's coming out, and again, Suzanne, you mentioned this in your report and it's appearing on the national system, is about the flow out into the nursing homes, particularly in the first and the second wave, and also the concern about contraction of coronavirus when patients are in hospital. And in some hospitals that reached 25 to 30% of the people with COVID had caught the infection whilst they were in receiving care for another reason. And I think that kind of points to a fact that in the new world, what we do need, and Andrew's told us this those times, the hospital needs to do what it needs to do to get people well, and then we need to get people home in the places where they want to be and with their loved ones. And that's the ambition. So the idea that you have a kind of rehabilitation time or a holiday in the hospital, we've just got to get away from that. We've got to work out how we meet those needs. And I think that's what you're seeing, Aaron. And I think the system together, we've got to adjust with that together.
Yeah. No, I think that's really helpful, David, and it's entirely flow dependent, and then flow across the system is the issue, as well as in the hospital, because of course it all, as you well know, Aaron, it all joins up. The only thing I was going to maybe sort of ask Tom, put him on the spot possibly, but Tom, is there anything you want to say about the work that we're doing out in the community with the 2-hour response, which and the paramedic kind of piece, because they're bringing a business case to us, aren't they, around that? I know.
I mean, I think it's a really important part of the picture, and we've had a really successful pilot on that. I can't bring the kind of results of the pilot to mind, but we can certainly share it with the board.
Yeah.
And I think we're now at the point where we need to scale that up, and I think that's the decision that the alliance needs to make. But it's a key part of the overall picture, I think, that David's just outlined in terms of what we can do to respond better when emergency hits an individual in their home or in the community, and what does that response look like, which prevents them having to be brought into hospital, because of course as soon as somebody gets into hospital, it's very difficult then, unfortunately, to do anything but admit them if they've got a range of needs. And the primary care, the GPs working with the paramedics, has proved itself to be a really successful formula in terms of keeping people independent and managing their condition and their crisis at home.
Yeah, no, thank you, Tom. I mean, one of the things that often happens is we do little tiny pilots, small scale, show great benefit, and then we don't actually have the cash to invest to make it big impact. And that was the conversation we had at the ICP board. We absolutely have to scale some of these things up. And that might mean us supporting that in terms of investment, which, in the current circumstances will be challenging. I can see Dami. I was going to come to you, Dami, because here we are with a primary care clinician sat at the board, so to give a perspective, and I can see you've got a comment in the chat there, so thank you, Dami.
Sorry, I put quite a long comment in the chat, just picking up on quite a few points. I think the issue about educating patients and educating our population on really where to go to seek help, I think it's a crucial piece of work that needs to be done. But obviously this doesn't affect the trust, only affects all of us, even in primary care. And even with a range of ways of accessing care, so ranging from telephone, videos, face-to-face, which we are doing, certainly in North Central London, we're doing about 30 to 35% of face-to-face appointments, is still not sufficient to meet the demands. And this whole conversation about limiting patients from coming to A&E, I know that this is a big thing that's been discussed across the healthcare system for many, many years. And I think we need to tackle it at so many different angles. We need the prevention angle, the education, the enabling self-care, where schemes where patients can seek help from the pharmacist without needing to come to hospital, and social care. We need to fix that too, But obviously that's not for us at this trust board to deliberate on, but those are conversations that we will need to feed into at a system level to be able to, protect ourselves and reduce the risks that we are experiencing clearly with the A&E service at the moment.
Thanks, Dami. So Andrew.
Yes, I agree with all that. I'm just going to say I agree with what David's saying, and I mean, really, there is a real challenge here for the NHS nationally. It needs a different narrative. If you listen to what the BBC and many of our journalists, of course, running around Westminster, I watch them chasing after politicians for the latest story. The stories is an out-of-date story about hospitals, really, and it needs a modern story about health and the social determinants of health and a whole integrated system, actually. And just so you know, so Lord Crisp and I, a number of us in the House of Lords, actually, have been in the healthcare system for many years, have been pushing over the last few years for that different story to happen. And it now becomes, in my view, ever more critical for the reasons David and colleagues are quite rightly saying. And sometimes that story, of course, sometimes things don't originate at the centre. They need to originate on the ground in real communities. So myself, I'd encourage you to encourage that different story, really, because it's desperate. It needs to happen, because the general public are misunderstanding the role of hospitals in the modern world and how they fit with GP practices and the wider offer of health. It's the fundamental question we need to return to as a nation, which is, what is health?
Yeah, thank you, Andrew. I'll take a last question from Aaron. Yes.
Thanks, Andy. It's another question for David, actually. It's just about the fact that has there been any conversations with GPs in the patches around our hospitals with respect? I know there was communications recently from Nikita Kanani about reinstatement of face-to-face consultations. Is there a view of what the primary care around our patch is going to do in the next few months? And are they going to, because I know there were even pre-COVID some practices.
Is it just me, or have we all lost?
Oh, we've lost
Aaron?
you, Aaron, at the end.
Oh, sorry. I've been. Yeah. I don't know why it went on mute. Where did you
my
hear?
fault. My fault. I was trying to lower your hand and I muted you instead. Sorry.
Chair.
I don't normally mute non-executives.
No, offense taken. It was just basically, I'll try to summarize very quickly. It was, is there a view of what practices around ASPH are going to do? And because I think that will have a massive impact on our A&E services in the next few months.
Yeah, so, well, I think that letter has had a positively negative impact, Aaron. It has gone down extremely badly because I suspect, well, I know because I've spoken to the GPs, what we're doing. So my sense is, from talking to my GP colleagues locally, is they are absolutely working their, as hard as possibly they can to do everything they can. And obviously, don't forget, our UTC is run by our local GP federation, so they're absolutely experiencing the same urgent care demand that we are. And really, it was more a conversation we had, wasn't it, Tom, about how we can help them actually, and how we can come to a shared plan. So I don't think anything massive is going to change in the next few days or weeks, actually, because I just don't think they've got the capacity to do anything other than keep going. But what we all agreed was we need to do something different. And the key thing we've agreed to do differently more quickly is to ensure that the MDT teams around the PCNs are fully enabled, that there's a clear team associated with each PCN, that we've got those resources in place and that we've got those teams enabled and that they're clear about what their role and functionality is. And I thought actually those were good actions for us to agree. And we agreed to work with the colleagues in primary care to understand what the data's telling us, because what often ends up, and David sort of alerted us to this, is you end up in a place where we're saying, oh, we're very busy in the hospital, and clearly it's just because the GPs aren't working hard enough, and the GPs get understandably a bit irritated by that and this whole old-fashioned conversation about how busy the hospitals are. So we're being really careful not to be in that place. And of course, the letter didn't really help I don't know. Tammy would have got the letter too. I don't know how she felt about it.
I think we just ignored the letter.
Okay.
Yeah, fair enough. Just a comment and a couple of quick questions from me to wrap this up. Just to say, and I think it's back to Chris's point, that the walk-in centres, just like our A&Es, have gone very busy. If you take it back 3 months, they were like ghost towns at a weekend. Now they're chock-a-block, just like the UTC, just like A&E. So that's common across the system. The accelerator money, our share thereof, I'm presuming that's revenue, not capital. It couldn't be capital.
There's a little bit of capital within it, which we will obviously ensure that we get access to. But it's predominantly revenue. And I suppose, as we've previously said, the actual cost of mobilising that additional, meeting that additional demand possibly outstrips the money available. So we need to be very careful in how we go about that. And in any event, in the current financial position, which we'll come to, managing the costs of the delivery of care is going to be an important part of our approach.
Yeah. And the final one was, I saw Elliot Ward up and running, which is obviously key to doing more electives at Ashford, but the enhanced care unit wasn't up and running. And I wonder if we've got a timeline to get that, because obviously we need to do more complex things there.
Yeah, so Tom will know when it is. We've had some delays as a result of COVID with some of the installation, but I think it's nearing completion, isn't it, Tom?
End of July, I think we're working to now.
Okay.
Yeah, so still a little bit off, but yeah, I mean, we've been a victim of the now publicised challenges around getting building supplies and stuff into the country. So yeah.
Okay, right. Good debate, I think, on the performance report. Thank you for that. We'll move on now, given time. Merrick, anything you want to bring our attention to on the Modern Healthcare Minutes?
Yes, really, we've been focusing a great deal on the financials and trying to estimate what they start to look like in a new world coming out of this, as Suzanne's just touched on. And the volumes alone are a challenge, let alone the fact that effectively the funding mechanisms are going to change at a time when we're changing from working in a COVID, all our funds are covered, to a more normal mechanism, but a change mechanism. That's still very much work in progress. And Simon, thank you for keeping us abreast of those constant and evolving discussions on our income plans for the year that we're now in. In relation to capital, we've covered it in both the closed board, but also in Suzanne's very detailed CEO report. Really, this probably is a bigger existential threat to some of our ambitions that we have, where we have, as we've already noted, the capital cash, but not necessarily the capital envelope within the new environment to spend all the money. That means a lot of detailed work on re-evaluating capital plans. Again, we're investigating and reviewing those at Modern Health. And as part of it, just to praise myself as chair in more detail, I have kindly been escorted around with Andrew and Chris around both sides. And Tom and Simon, thank you for the working draft of the capital plan and how that's going to evolve. And as I say, I think this will be an area of further focus for the committee looking forward. Thank you.
Thank you. Yes, and I think we're all across the issue with the capital now. Simon, have you got anything to add, or?
Not particularly at the moment. I think we've covered it in terms of the challenges and risks.
Yeah. And I think we're absolutely right to have accelerated, enhanced that risk around around the capital. So I think that's absolutely fine. Okay, Chris, the digital committee minutes. Chris, are you there? We're not hearing you.
No.
It would be the digital lead that's got a problem coming back on, isn't it? Still muted.
Can you hear me now? Good, sorry. I think a lot of this has moved on, and we've covered stuff today anyway, and in the closed board. I guess the ITC is really now, IDC is really focusing on the refinement of the BAFT, making sure that we understand our KPIs, that we're taking mitigation actions to lessen the risk. And I think that's all good stuff. We've in terms of key topics covered, very much around Surrey Safe Care, and we know where we are there. That's a sort of, it's a good news story, but it's a challenging one still, and remains to be, but it's remaining on course. And I guess we've also discussed in the closed board, but went into detail in terms of the discussion with the Catherine Church and the ICS, and had a very constructive discussion in terms of how they're developing resourcing and their areas of work, and the alignment with the trust work. So I thought that was all very good. And of course, in looking at the digital program, I mean, most things actually are on green and amber, so they're pretty good. And we're putting a digital program committee in now to make sure that we mop up all the various initiatives that are now happening across the trust and have accelerated to ensure that we have the appropriate resourcing, focus and governance. But that's really all I want to say, unless anyone's got any questions.
So any questions for Chris on the minutes? I thought they were very clear. Okay, thank you, Chris. And last but certainly not least, the People Committee minutes, Marcin.
Thank you, Chairman. Again, our minutes from March, so I'd rather focus on last week's meeting. You'll have read from Suzanne's report, covers the key issues. We still continue to focus the people issues on our 3 risks. Do we have the right people in the right places? Can we recruit and can we keep them? And are we listening and engaging in them? I think 3 things popped out for me at this last meeting, which is the excitement around this wonderful program called Grow Your Own, and what a testament to listening to Ralph today to see it in practice. It's a big program. It's got big issues, big priorities, and the thing that we recognize and took away is that the resource needed to do a massive Grow Your Own program is required. And the plan, Louise will bring a plan to the People Committee in September with laying out exactly how we engage with our schools, our universities, colleges, and our community to grow our own. I would also tell my board colleagues that the vacancy rate continues to reduce, and that's the success of the recruitment hub, which is amazing, of the initiative that Louise's team has put in place. That has other issues for finance, which Merrick talked about, but the fact that we've got our own staff in there and are getting them from the community is fantastic. I think the big issue that we reflect and why our risk on retention remains red is the concern about post-pandemic exhaustion. Actually, I saw one of our consultants yesterday and she said it's all just more difficult. The cases are more complicated, patients are more complicated, the whole environment's more complicated. I think people are exhausted, and I actually saw it firsthand. So the HR team are putting in a new exit interview process. We're trying to actually get in and really understand what's going on with the people that are leaving. Lastly, something that we've now put on as a standard item to our agenda is the Equality, Diversion and Inclusion agenda. Again, another big program, very exciting. It needs resource, it needs prioritization. And I know that with Suzanne chairing that group and they're bringing their minutes and the dashboard to our committee, we will continue to see progress on that agenda. And I just last to say that we had heard some issues around employee relations, but we are pleased to see no increase in cases, but again, just more complex cases taking more time. And that's very difficult with a very small team. So we really feel for that group. And their papers we get are excellent. We had some good reports on assurance in terms of overpayments to staff, and as I said, on the volunteers. So we're starting to link in with the Audit and Risk Committee, and I was pleased about that. And that's all I'd like to say. Thank you very much.
Thank you, Marcin, and good to hear the latest from the People Committee. As I say, the minutes are obviously fairly historical at the moment. So any questions for Marcin? Okay, thank you. So move along to the final big section, which is regulatory. And the first one we've got is our normal NHSI self-certification that we've got to do. So Suzanne, you're going to, this is something for approval, isn't it? We lost Suzanne.
I'm here to, yes, but there is a difference to the requirement which is explained within the paper, which Sal has, to be fair, is the expert. But you will recall this always was a mandatory requirement for us to complete and publicise, along with a template we had to complete in order for us to maintain our licensing arrangements. My understanding, although Sal is here, Sal may be here, she there she is, she's the expert, but we no longer are required to submit the template, but we are, for good governance purposes, continuing to bring this here and have it approved, providing that you do, because a number of foundation trusts will be called upon to demonstrate that they have done so. So it'll be more of a sort of a compliance as opposed to everybody just blanketly doing it. So that would be my overview. Sal, anything to add in the detail?
No, I think that covers it very well, Suzanne. Thank you.
So we'd like your approval, please.
Okay. Any questions on anything that's in this? I say we've seen this before many times. Yep. So I think you've got your approval, Suzanne, for that.
Thank you very much, everybody, and particularly thanks to Sal for the paper.
So we now have got the standing orders, which amazingly, Sal, you've got my name against. We'll talk about that later. So Sal, anything you'd like to draw our attention to on the standing orders?
No substantial changes, Andy. Again, this is an annual requirement which accompanies the Register of Interest and the self-certifications. So it's a normal governance process of us annually updating, and no significant changes for approval.
There's one thing I spotted in it, and that's right at the beginning, where we're talking about written notices, sending by email now to directors. But should we not be putting email or board software in there? Because that's how we're really doing it now, isn't it? It's not always email.
Yeah, we can add that. Yes.
Board,
no
I would
problem.
say board management software would probably be the catch-all, wouldn't it? And we don't want to put any brands in there.
Yeah.
Because that just reflects what we're actually doing. Any other amendments? Marcin, you've got the eagle eye normally on this.
I wasn't even going to say it. Because I did, of course, read all 35 pages. And one of the ones that I was questioning, but I was going to take it offline with you, Andy. Appointments to committees, it says is agreed by the board, and that actually isn't our practice. Our practice is it's a discussion between you and the NED, and you and the NED decide which is the most appropriate committees for a NED to attend. I just wondered whether we want to maybe tighten that up so it's not a board decision as to who's appointed to which committee.
I think probably the best. It's a really good point. I think we can.
It's very minor.
No, we can reflect that and say perhaps ratified by the board.
That because I know that maybe that's something we'll be doing in June with all our new NEDs and going through all the committees. But I just thought that maybe we could just refine that one item out of 35 pages. You know, I love standing guidance, and I'm pleased to see we do comply with all of it. It's excellent.
Thank you, Marcin.
Thank you.
Thank you for reading all 35 pages again.
I'm sad, aren't I?
No, you're not. You're absolutely necessary.
Oh God.
Right. So we'll do that now. The next one is the board register of interests. Now, has every board member updated this, please? I just want to know if it's accurate. Suzanne?
Mine isn't quite accurate. I have updated it, and it's probably my poor transcription. So, Liz, I'm no longer the chair of the BSPS board. I am a member.
Okay, I'll update that, Suzanne.
Thank you.
Are all the NED ones up to date? I'll take that as, yep, okay. And obviously, although these come, David, sorry.
Well, I was just that I have updated mine, but I was just looking at Suzanne's, and I just, I might just have a chat and work out what we put on that about membership of boards within the system, as it were. So that's, I just need to work out what the guidance is on that.
Yeah, yeah, I think that's right, because I looked at the executive ones and I thought these come with a job, and they're not conflicts as such.
However, our standing guidance says is that if you do any work within for another NHS organization or organizations, you must declare it. So actually, one of the questions I had was Dammy, whether you being a GP, you ought to actually record that. So that's just a minor point.
No, that's true, and it's right, absolutely right. Okay, so I think we've received that, and we'll get that updated, and it'll be back. I think it goes on the website, doesn't it, Sal? Yeah. Okay. Simon, the weighty matter of the trust seal.
Yeah, so we signed 4. I think it was in late March. It's to do with the land sales back in, what was that, March 2019, I think. Each year we receive further cash from Carla. In March it was £12 million, and those documents release our charges over the land for the relevant bits. There's one more payment due to us, another 6 million in March, in whatever that is, 22, I think. At which point all of the land charges would be extinguished. So really it's just transacting that. There was a few more changes behind the scenes. Surrey and Borders wanted to defer one of their capital receipts, and we had to acknowledge it. It's to do with their rebuild programme of the Abraham Cowley. So I think that was why there was maybe one more document than there had been in the past. But relatively straightforward, Andy.
Okay, thank you. And we're just receiving those, aren't we?
Yeah.
Just sorry to go back, but Sal, on the standing orders, there was another thing I picked up, just to show I can read 35 pages as well, that we've got under the procurement, EU directives governing public procurement. I think that's changed. I don't think we're in the EU anymore. So, and I think the new procurement legislation is going through. Whether it's through at the moment.
So I think it's a transition issue. Whilst we wait new legislation, the previous legislation is no doubt still in, or at least the UK's version, alignment with that. So I think, I will check, but I think
that's my understanding too for public procurement rules, because that affects my organisation.
Sorry, say again, Neil.
That's my understanding too, that public procurement rules as drafted, which were in accordance with EU legislation, haven't yet changed, although they're due to. I think there's a white paper published, but it hasn't yet changed.
So I think it will change in due course, but I will check that for us.
So I think if we change that to UK directives governing public procurement, even though they are still aligned with the EU, that's probably the right way to do it.
Okay.
So sorry about that, going backwards. Now, I haven't been notified of any other business, but has anybody got any other business? No? Okay. Liz, have we got any questions from the public submitted?
No questions received from the public this time.
Okay. All right. We'll unusual, but that's fine. And reflection on the meeting. Wendy, I don't know if you want to give any reflections or whether you want to do that privately through Andrea.
I would probably prefer to do that privately via Andrea, but thank you for allowing me to attend. It's been really interesting and inspiring.
Okay, thank you. Thank you very much. And we welcome any observations that you have for us. That'd be great. Okay, so the next meeting we have of Open Board is on the 29th of July 2021. I just want to say thank you to everybody. And I know we're meeting again shortly as Strategic Change Committee, but thank you for all your input this morning. And I think we've gained good assurance on all the matters that we've covered on the agenda, both quality, performance, etc. So thank you very much. And we'll see those of you again on the Strategic Change Committee in due course.
And we want to eat Ralph's food.
Marcin, could you stay on the call? I just want to ask you a question.
Of course.
I need a bit of advice about something.
Okay.
All right. Thank you, everybody.
Bye, everyone.
Thanks, everyone.
Thanks,
Bye.
everyone.